begin with, I think we have to acknowledge where we stand now, that it's a very serious problem, that it's very widespread, that it's the number one cause of cancer-related death, that there are more than 200,000 diagnoses in this country every year. And I think that the severity of the issue is really brought home by the number of deaths. It is a serious problem. But what distinguishes the last 10 years from the prior decades is a rapid improvement in our understanding of the disease, the development of new treatments, and the identification of how to give the right patient the right treatment. The new understanding began really in the last 15 years when we started to identify subsets of lung cancer. Previous to that, there was the approach was all lung cancer patients should be treated similarly. That really had limited efficacy. In fact, for a long time it wasn't clear that any treatment was helping at all. Even in 2002, there was disappointing results. Since that time, we've identified new mutations that cause cancer in even up to 20% of lung cancer patients. With that knowledge, we're able to target that mutation and in some cases with minimal side effects, have a dramatic benefit in the patient's quality of life and time of survival. The pace of development can't be overstated. I think when you review what changed from 1950 to 2000, it is vastly improved in the last 10 years. To specify, there are 4 stages of lung cancer, and the first 3, in general, we try to treat a patient for cure. That means removing the tumor, treating tumor that can't be removed with radiation. And chemotherapy has played a role in improving the efficacy of radiation and in preventing a removed tumor from coming back. That improves our ability to cure people by a significant percentage. That is really a remarkable advance in the recent past. That leaves the stage 4 lung cancer, which has spread and is unfortunately not treatable by surgery. There, the primary treatment is with chemotherapy. Radiation may still have a role for symptom control, to minimize breathing problems or to improve pain. But the survival benefit comes from chemotherapy. To talk about lung cancer, it's really a combination of many different types of cancer. The most common is non-small cell lung cancer. It is approximately 80 or more % of lung cancer diagnoses. I'll also discuss small cell lung cancer. Small cell is particularly associated with tobacco use. It is also one of the fastest growing cancers that exist. For that reason, it responds very well to initial treatment, chemotherapy and radiation, but it becomes resistant to treatment. So the current research approaches are how to direct treatment to those resistant cancers. There are also rarer kinds of cancer that don't fit into either of these categories: sarcomas and carcinoid tumors. And because of their rarity, I will focus less on them today. To discuss small cell lung cancer further, the recent developments in our understanding show that as in non-small cell, there are certain signals within the cell that tell tumor cells to grow and to survive longer than they were supposed to. One of these is BCL2, and specific inhibitors to this process have early signs of possibly being effective, improving response rates, and we hope to see improved survival. The development of new hope for small cell lung cancer, I think, is one of the important goals for lung cancer researchers around the country. I think all too often small cell lung cancer patients may feel that they have been ignored, and many people are working to readdress that. Several studies have shown even earlier this year that new combinations of chemotherapy may be particularly effective for recurrent disease, even for disease that has unfortunately spread to the brain. As we learn how to better treat these patients, to allow them to maintain their function, patients will feel better, and we hope to see live longer. One of the things that makes the lung cancer experience for patients unique is the role of tobacco as a causative agent for most patients. I think that this has led, unfortunately, to a stigmatization for patients and a sense of shame for many patients. And it's particularly unfortunate when that impedes people from getting proper care, and from, unfortunately, even doctors from sending patients to the proper specialty centers. One of the focuses, I think, of a doctor is to reassure a patient that you understand the addictive nature of tobacco use, and that you will support the patient through the process. Hopefully, someone that continues to smoke would be willing to try to stop, and that can be supported in as many ways as possible. But I think the sense of shame that patients feel can really add to the suffering, and that's unfortunate when it doesn't have to be that way. At the same time, there is what seems to be an increasing rate of non-smokers getting lung cancer. More than half of the current diagnoses are in patients that are not currently smoking. And if you look at people that never smoked, as many as 1 in 5 women with lung cancer never smoked, and approximately 1 in 12 men with lung cancer never smoked. That number seems to be increasing, and it seems to be that those mutations that I discussed, EGFR mutations, a newly understood gene rearrangement called an ALK fusion event, that those are important causes for cancer in a non-smoker, and that they may be particularly benefited by some of these targeted drugs. Also, as well understood, women are increasingly found to have lung cancer. While there has been an encouraging decrease in diagnoses and an improvement in survival in men with lung cancer, a disturbing trend of increase in women has been seen. This is partially due to smoking, but not entirely. And as we better understand the process, we may be able to help more and more patients. Another noticeable change is the number of young patients, often young people who never smoked, who are developing lung cancer. Just this week, I've seen 3 people in their 20s recently diagnosed with lung cancer. It is, of course, a disturbing and terrifying event.